Hello guys, I am Abhijeet Sekho, a medical student from SMS Medical College, Jaipur, and today I will be presenting the OBGY case that is given to me by Dr. P.K. Sen Medical Firm. So let's get started. So this is the case that is presented to me. A 30-year-old gravida 5 para 4 at 32 weeks of gestation complains of significant bright red vaginal bleeding. So let's get a pen and let's highlight the important aspects of the case. So here we have a multigravida and she is complaining of significant bright red bleeding. She complains of no uterine contractions or leakage of fluid, and she has history of cervical trauma due to sexual intercourse 4 weeks prior to the presentation, which was followed by vaginal spotting. Her vitals are within normal range. Abdomen is soft, tender, non-tender. Fetal heart rate is within normal range. So what does it tell us? So this is a clear-cut case of antepartum bleeding. So this is the image which was given with the case. This is ultrasound which is showing us bladder, placenta and cervix. So we come to arrive on the differential diagnosis of antepartum hemorrhage. I have written all the possible differential diagnoses which are more likely in this case. So first we have cervical trauma, placenta previa, uterine rupture, vasa previa, stillbirth, rupture of membranes in velamentous cord insertion, bloody show and placental abruption. I have also written the important aspects of each and every case, as you can see, and this will help in deducing the case. So the clues and algorithms. Let's get the pen. So we have our case which is showing painless bleeding. So this rules out placental abruption, uterine rupture and stillbirth from our differential diagnosis. We have significant bright red bleeding which rules out cervical trauma, bloody show, because cervical trauma and bloody show, as we can see, bloody show and cervical trauma are only associated with vaginal spotting, not a significant bleeding. And then we have normal fetal vitals, which rules out velamentous cord insertion, as it is often associated with fetal hypoxia, and then it also rules out stillbirth, vasa previa and placenta abruption, which is often associated with fetal distress. So this, after rolling out all these differential diagnoses, this is simply a case of that we have written our second point, that is placenta previa, which is associated with painless bright red bleeding. And in this case we also have various hidden clues which also support our diagnosis that we'll see now. Placenta previa is supported by, as she is a multipara woman. Multipara woman because in multiparous women the placenta previa is very more likely, and then she has painless bleeding, her uterus is soft and non-tender, and also a clue which is very hidden, and that's why I commend the form which has given me the case, because this hidden clue, that is leakage of fluid, is not present. So her membranes have not ruptured yet. So this also supports our diagnosis of placenta previa, because it often occurs before the rupture of membranes. And also the ultrasound which was given to us is a diagnostic which shows low-lying placenta, as we can see here. So this makes the placenta previa the most probable diagnosis here. In the management, it is simple that in 37 weeks and less gestation with no active bleeding or fetal distress, expectant management is done, which we'll talk later. And with severe bleeding or fetal distress, stabilization and immediate cesarean section is done. And in more than 37 weeks, immediate delivery is done. Talking about the expectant management, we do first of all, we hospitalize the patient, observe her for 48 hours. If her age is less than, let's get a pen, less than 34 weeks, then we will do the fetal lung maturity, which is induced by giving corticosteroids like betamethasone. If her age is between 34 and 37 weeks, then and delivery is likely within 7 days. This is very important. Then lung maturity is induced with corticosteroids, and if mild uterine contractions are present, then tocolysis are done, because we don't want her to deliver just yet. Route of delivery is always as I have written that preferred route of delivery is lower segment cesarean section, and ideally it is scheduled at 36 to 37 weeks of gestation. And but we can also induce labor if following conditions are met: that mother is hemodynamically stable, fetal cardiac status is reassuring, and the placenta lies more than 2 cm away from intercourse. So thanks. So this is our case, which is I would say quite fascinating.